My name is Anissa Mitchell. I'm with PMD Alliance, and today we're going to be talking about palliative care and chronic disease management. I know many people have heard the term palliative care. We know that sometimes it gets associated with hospice and end-of-life care. Today we want to talk about what it actually can mean in terms of managing a chronic neurodegenerative progressive disease. And with us today is the expert in the field. We have Dr. Benzi Kluger. He's actually a pioneer in the neuropalliative care space. It's a field dedicated to the radical idea that improving the lives of people affected by neurological illnesses actually requires treating them as a whole person, which is what this is all about. Dr. Kluger is one of the first team-based neuropalliative care clinics in the world from the University of Colorado. He is now with the University of Rochester. He's published numerous papers important to the growth of this field, and his research focuses on neuropalliative care, fatigue, and neurodegenerative illnesses such as Parkinson's and Alzheimer's disease, with some brief excursions into other areas, including nutrition, acupuncture, and cannabis, which I think could be interwoven into quality of life and whole person care. So he is going to be our speaker today. And yes, please open up your chat boxes. That's where your questions are going to be today. We're going to hold those until the end of the program. And do give us a shout out and let us know where you're joining us from, because we just love to know who all is in the audience today. So I'm going to hand this over to you, Dr. Kluger. Thank you so much for being a part of this conversation today.
All right, thanks for having me. See a few familiar faces in the audience. I'm going to share my screen. And here we go. Okay, so the talk today is starting off, and this is really the focus of palliative care, is living as well as possible for as long as possible. So an introduction to neuropalliative care for people with Parkinson's and also related conditions like PSP and cortical basal and MSA and other things that may look like Parkinson's. The same principles definitely apply. So my goals is to, even if you think you know about palliative care, to really get people up to date with current definitions of both supportive and palliative care. To understand why supportive and palliative care are relevant to everybody living with Parkinson's disease, and to make clear this is people from the time of diagnosis all the way through end of life. To talk about, I think importantly, how you can use a palliative care mindset as a framework to improve self-care and resilience, and how you can use this skill set to improve the care you get from your current healthcare providers. And part of this came from me really being pushed by people I was taking care of, and from talks like this where people ask me, where can I get this care? And oftentimes people don't have a shingle up on their office saying that they provide neuropalliative care, but if you're able to ask the right questions, you can oftentimes get your healthcare provider to give you palliative care, even if they don't realize that they're doing it. And then we will also talk about, and this is something that is rapidly growing in terms of what's available, of where to go if you feel like you need specialist supportive or palliative care to get an extra layer of support for challenging situations. And this is something that's grown quite a bit since I first started over a decade ago. So I'd like to start with a little bit of personal background because I think it's relevant. So when I started in neurology, I did not go into neurology thinking I would do neuropalliative care. And in fact, when I started neurology, there was not such a thing as neuropalliative care. So I went into neurology thinking that I was going to do neuroimaging research and understand where fatigue lived in the brain and all kinds of things like that. And after I finished my training, what I rapidly learned was that all of the things that drew me into neurology about figuring out the right diagnosis and getting the right treatment and stuff like that were fine, and that aspect of my life and my cognitive life was fulfilled. But I think the more important thing was that my heart was aching for the people I was seeing. And I was seeing people with Parkinson's, with Lewy body dementia, with other illnesses. And I was not trained in terms of how to really best address the sources of suffering that most bothered them. And I felt very helpless. I felt hopeless. I actually thought for a time that I might leave medicine, but I was fortunate in two ways. One was that I ran into a woman, Jean Kuttner, who's at the University of Colorado, who introduced me to palliative care, which at that time was really focused on cancer. And as I learned more about palliative care, I asked her the question of, why aren't we doing this for neurology? And she said, I think you've got a lot of work ahead of you. And I was also lucky that I began working in Buddhism and at a monastery. And so I would say my spiritual journey and being able to sit with and work with and open my heart to suffering was an important part of this. And I'm happy to talk more about spirituality later if people want to. Another big piece of things was really thinking about and listening to and talking to patients and families living with neurologic disorders and finding out from them what's most important. On the left, at least of my screen here, is a gentleman, Kirk Hall, who some of you may know. He has a blog. He's written a book about the fear of developing dementia with Parkinson's. He has a couple of children's books called Grandpa Shaky Paws. And I credit him really for bringing me into the world of palliative care. And we actually recently talked about this, and he corrected my memory, but I think part of it came about that we were reading a book, or he shared a book with me, written by a guy, Tom Grabois, who was a cardiologist at Harvard who developed Lewy body dementia, and talked about his philosophy of care as a cardiologist. And I think for both me and Kirk, seeing how that philosophy of care was absent in neurology, or at least sorely lacking. And so that was a starting point for us. Also of relevant was that Kirk invited me to a support group to talk about death with dignity, which is something that we can talk about. But it was something that was not at all on my radar screen from my training as a neurologist. But it's relevant. And in fact, the law of medical aid in dying in Colorado was put forward by somebody with Parkinson's disease. So I learned that even if people in clinic are not telling us about things because we're not asking the right questions, doesn't mean that people with Parkinson's aren't worrying about some things that we should be asking about. The two lovely young women that you see on the right side of my screen, Carissa and Juju, were two girls who had young onset Huntington's disease. And that was another turning point in my career. Carissa, who's the older of the two, I can remember clearly she came in when she was 20, and I was asking her my usual questions. I was asking her about her sleep, and she told me she was afraid of dying in her sleep. That was why she had insomnia. And that was a light bulb moment for me, because it made me realize for the first time what spirituality meant in the context of medicine. That her inability to sleep was not a medical problem. It was not something I was going to fix with Ambien. It was something that would require us to acknowledge what was going on with her and to talk about the things that she was afraid of. And so actually within a month of that conversation, we had a chaplain in our clinic, and we really began our team-based efforts. So that's where I'm coming from. So what is supportive and palliative care? And it's about living as well as possible for as long as possible. And I underline living because there is a big difference between living and surviving. And our work in palliative care actually reinforces that when people are seen by our palliative care clinic, they feel like they're really supported in living as well as possible, not just surviving. And living includes all of those things that bring us joy and connection and meaning. And that's really the heart of palliative care, is how can you flourish and thrive and live your best life possible despite having an illness that you never chose and that is awful in a lot of ways, which is Parkinson's. So it's finding that balance between being honest about what Parkinson's is and also maintaining hope for what's really important in living a good life. The essential elements of palliative care, which is from an updated definition of the World Health Organization, I'm going to highlight a few. The first is really to emphasize that it's about enhancing quality of life, and that includes reducing suffering. So that includes addressing things like pain and constipation and fatigue, but it goes beyond that, and it also goes into how do we help people feel resilient? How do we help people spend more time with their families? How do we give people a bigger sense of control of their life despite having a serious illness? It offers support to both patients as well as their families. And I think that's also critical with an illness like Parkinson's disease, that Parkinson's doesn't just affect one person. It affects a couple, it affects a family, sometimes it affects a community. And we need to provide support for everybody impacted by that illness, not just the patient. We provide relief from pain and other distressing symptoms, which is not surprising. but we also address emotional, social, and spiritual issues that go beyond what we typically talk about in clinic. One example of that is when I ask people, are they depressed? People will sometimes say yes, and then I'll pause and say, I want to make sure we're talking about the same thing. Depression is a chemical and a psychiatric disorder, and that's different than grief, which can be a sense of sadness from losses in your life or frustration from having an illness and not being able to do the things you want to do. So we want to make sure that we address normal but difficult emotional and spiritual challenges, while at the same time not missing things like chemical depression, and both of which can happen in Parkinson's. We also affirm life and regard dying as normal processes. And I think one of the things here that's important, and that I've heard from people in our clinic, is that they feel less alone in their suffering when they're with the palliative care team. And that's because, doctors, as well as our society, as well as families, don't like talking about tough things. They don't like talking about the fact that Parkinson's is progressive. They don't like talking about the fact that people can die of Parkinson's disease. And so people are left alone with their worries, and we want to make sure that nobody feels alone with whatever they're concerned about. And the last thing that's important is that this model of care is applicable throughout the course of illness. And in fact, I see actually Gil Thalen is online here as one of many people who brought this to my attention, is that when people get diagnosed with Parkinson's is often a time where they have some of the highest palliative care needs, and that we really need to provide extra support for people around the time of diagnosis, not wait till later on in the disease when things have progressed. Palliative care is the same thing as supportive care. So I just want to be clear about that. And there's been a lot of research about the importance of names. And from the cancer world, and this has also been true in my experience in the neurology world, is that people are about 10 times more likely to go to a supportive care clinic than a palliative care clinic. And we've in fact gone to the detail of training our schedulers on how to talk about this, because we found that people referred to palliative care often refused to go to palliative care because they said they were not ready for that, or their doctors had problems referring them because their doctor said, oh, you're not ready for that clinic. And so we use the word supportive care instead of palliative care, but they're really interchangeable. And supportive care is just more intuitive. We're providing an extra layer of support, and this could be at any point in your illness. But just to be clear, if you see those two terms, they're really the same thing. The three-legged stool model of palliative care came from Kirk Hall, the patient I mentioned earlier, and it's something that I've been using ever since. And it's this idea that we want to think about palliative care as a public health good. We want to think about palliative care as something that we want to provide for everybody living with Parkinson's disease. And if we want to do that, we have to have palliative care specialists. So people like myself, hospice doctors, palliative care doctors who understand Parkinson's and can provide good treatments from a palliative care side. We need to have community and disease support organizations like the PMD Alliance and the Parkinson's Foundation and others who understand palliative care and can provide support groups and resources and education to support everybody in the community. This could also include things like adult daycare and other social services. And lastly, we need primary care providers and non-palliative specialists, so neurologists, to understand palliative care and to have a basic palliative care skill set so that we can provide preventative palliative care early when people need it, and not have people waiting to be referred often to services that may not even exist in the area. And so this is kind of the goal and the dream, is that all three legs of the stool are strong and well developed, and we're able to give everybody the palliative care need where they live and when they need it. Part of the team that actually wasn't in that diagram, but maybe should be, is the person living with Parkinson's and their family. And so there's two big roles for the person living with Parkinson's and their family. The first is that palliative care is person-centered and family-centered care, which means that we need the voice of the patient and we need the voice of the family in the room in order to do good palliative care. My job is dependent on knowing what are the values that are most important to this individual in front of me. I can't make those assumptions. And this is different than, say, traditional neurology care, where if somebody has a tremor, my job is to treat it. In palliative care, somebody's primary goal may be to spend more time with their family. Somebody's primary goal may be to travel. Somebody's primary goal may be to continue working. And so if I don't know those values, I'm not going to provide the best care possible. The second question that I ask everybody is, what's the toughest part of this for you? So where is the greatest suffering? And then let's start working on that. And again, that can vary from person to person. For one person, it may be that I can't drive anymore. For another person, it may be pain. For another person, it may be their tremor. And then what opportunities exist for living well? So we want to talk about suffering, but we also want to not lose sight of what it means to live fully. And so I always ask people, what do you enjoy and what are you looking forward to? As a way to ground our conversation and see what are the opportunities to bring more joy, meaning, and love into this person's life. So that's really the core of the questions I ask and the work that I do. And the other reason that I think it's so important to think about the person living with Parkinson's and their role is that you have the power to improve the care you receive. So that's a really important concept. And patients and families can drive care in several ways. One is by setting the agenda for visits. So you can send an email to your doctor in advance. You can come into the room with a checklist. You can tell your doctor at the start of the visit, you know, I have 1 or 2 things that I really want to make sure that we address by the end of our visit today. You can bring up important conversations and topics and questions. And when you do so, you can let providers know that you're ready to talk about this. A lot of providers don't talk about some of these tough things because they're afraid that it may take away hope. But if these are things you want to talk about, you can let your doctor know that you want to talk about them and that you know that you're a grown up and an adult, and you know that it's going to be tough, but you want to talk about them anyway. Let your providers know your preferences for information. And I bring this up because not everybody wants to know everything. And so you might say, you know, I really want to know what to expect over the next year. Or you might say, you know, I really want to know what dying with Parkinson's looks like. I keep thinking about it. And I had a friend in my support group die, and I really want to talk about it so I can know more. So you get to drive that conversation. And then you also have a right as a patient. This is a right to request referrals or second opinions. So if you feel like your pain's not being well addressed, if you feel like you need more support, then you have the right to ask for it. And you don't have to worry about hurting the feelings of your doctor. If they're a mature healthcare provider, they'll be happy to do it. And if they're not mature, then that's their problem. It's not your problem. While we're talking about this, I think it is worthwhile. I'm not going to talk a lot about this, but we may circle back to it about what hospice is. So hospice is specifically palliative care for people near the end of life. And in the United States, for people with a life expectancy of approximately 6 months or less. That being said, the rule is that you have to have a 51% chance or greater of dying in the next 6 months. And so even with hospice, I focus hospice on trying to help people live as well as possible for as long as possible. And my record holder on hospice was on hospice for 6 years. And I think hospice actually helped that person live longer because it kept them out of the hospital and at home with their very tough and stubborn German mother who took amazing care of them. And we can talk more about hospice and how we can use hospice better, but I always try to get people, if their goals are aligned with hospice, to get it as early as possible. Hospice is a service. It provides wraparound medical care provided in your home or wherever you're living. It's rare that people go to a hospice. Most of the time, hospice comes to you. Hospice is paid for by Medicare and all insurances, and the goals of hospice are to maximize comfort, spend as much time as possible with family and as little time as possible in hospitals and with medical providers. So why is palliative care important for all people living with Parkinson's, not just people who are nearing end of life for hospice? And then I would say one of my favorite poets, Mary Oliver, that it kind of comes down to this quote is tell me what is it you plan to do with your one wild and precious life? This is why, to me, palliative care is so important. It's really about helping people with Parkinson's and their families flourish despite having a bad illness. And it's also about when we can't get rid of things, how do we find compassion? How do we live our best life? And how do we help people to let go and be comfortable if there are things that we can no longer get rid of? But it really comes down to how can we make the best of this precious and rare time that we have on this planet. And there's 2 core concepts related to this. So one is this concept of total pain. So in palliative care, Dame Cicely Saunders, who's really the founder of the modern hospice movement, one of her big concepts was total pain, by which she meant that having a serious illness like Parkinson's or cancer is not just physical pain, but there's also psychological pain. For example, depression, grief, frustration, anger, feeling like a burden. There is social pain, that there's isolation, there's changes in relationships. There's a lot of people who no longer feel like they know how to connect to you. There is spiritual pain, and that can be religious. That can be wondering why God gave you this illness. It could be a question of faith, but it can go beyond that. It could be, how do I make sense of this? This is not fair. Why did I get this illness? How do I find hope with something that I know is not curable? How can I find meaning despite all of this? Those are all spiritual and existential questions. And so palliative care is really about addressing this whole package of total pain and making sure that we support people with the total pain of serious illness. And with Parkinson's, you know, I don't have to tell you who are here in this room, is that Parkinson's has total pain. There's physical, motor, and non-motor symptoms. There's emotional things that come up, grief, worries, frustration, social isolation, loneliness, hopelessness, practical things. Can I afford future care? What am I going to do about transportation? How do I coordinate care about doctors? All of those practical issues, what's called time toxicity, the amount of time spent on medical issues, those are also part of the total pain of Parkinson's and are things that palliative care doctors are meant to ask about and try to help you do better with. We also want to find the positive without denying the negative. So I wrote a paper recently on the total enjoyment of life, which is the flip side of the total pain of illness. And so that includes where do we find meaning, which could be family, religion, our core values. Where do we find love? Where do we find hope, including for care, for better personal goals? Joy, which could range all the way from simple pleasures like eating more ice cream to travel. I just saw a patient last week who modified their RV and is always having an appointment from a place that I wish I was. I think last time I saw her, she was in Savannah in Florida and doing Route 66. So we want to make sure that we don't lose sight of opportunities for joy as we're doing this work. I put up this slide. This is an older slide, but I can tell you the data has not changed. The world mortality rate is flat at 100%. And I put this up there because I think the US healthcare system is one of the few healthcare systems in the world that pretends that death is optional, that there's always one more thing to do. We can get people in the ICU, we can put people on machines, but of course we can't. And so since death is not optional, what can we control? We control how we die. We can have some control of when we die. And I think it's important to know that Parkinson's is the 14th leading cause of death in the US. And I've done work, as have others, to make sure that people know about that. That doesn't mean you will die from Parkinson's. A lot of people with Parkinson's may die from something else. But we also want to make sure that people who have a chance of dying from Parkinson's are prepared and that they and their family can do their best so that they have the opportunity to die at home with family around and not in a hospital, which is something that most people really don't want. A big part of my work these days is to try to raise and change standards of care. And this means going from a biomedical model of Parkinson's, where we have this disease of Parkinson's and alpha-synuclein, and we have biological treatments and physiological treatments, towards a biopsychosocial model, where we still have the biologic, but we're looking at social factors and psychological factors. And to really bring this home, if you think about cancer and cancer centers, if you go to any cancer center in the country, you're going to find social workers, you're going to find chaplains, you're going to find summer camps for your kids. If you have an equally awful illness like advanced Parkinson's or ALS or Alzheimer's disease, currently you don't get any of that. And so that's a big push of the work that I do as an advocate, is to try to make care better and to develop parity for neurologic illnesses as we have for cancer. In work that I've done with the Parkinson's Foundation and others, we came up with a model of palliative care that we wanted to be memorable and measurable and actionable so that we could really drive change in the system. And so these 5 pillars are care that we think that everybody with Parkinson's disease should get from the time of diagnosis. And that includes being systematic and comprehensive in supporting people with non-motor symptoms like depression and pain, things that we know people miss about half the time. That we are systematic and comprehensive about asking care partners how they're doing and providing support for them. Similarly, that we're systematic about asking people about challenging emotions and their spiritual well-being, that should be something that our healthcare system is doing routinely. that we're at least annually looking at advanced care planning, so helping people to plan their future, asking them what they would want in the future, giving them guidance, and to have timely referrals for specialist palliative care and hospice. And I bring this up because people with Parkinson's, like any other illness in the US, tend to get hospice late, tend to get palliative care late, if at all. And what that means is that rather than getting 6 months or more of hospice, people on average get 2 days to 2 weeks. Meaning that they and their family get a lot less benefit and end up going through a rotating door of hospitals and nursing homes, oftentimes for the most precious and last few months or years of their life, rather than having control of their life. So moving on to this idea of self-care and the palliative mindset. So how can you start to apply these ideas, even as soon as today, as a framework to help anchor your self-care? And so part of it is asking some of the questions that I ask all of my patients and families, to ask them for yourselves and to spend some time thinking about it and journaling this. And I'm sure Anissa and the Parkinson Movement Disorder Alliance, I believe, are going to share my slides with you, or you could request them if you want to spend more time with these. But the first page is about how do we reduce suffering? And so what are your sources of suffering? What is toughest about this for you? And it may be obvious things like my hands shaking. It may also be not obvious things, like I want to be able to be more of a role model for my grandson, and I'm not able to be that, or my grandson's never going to see the kind of person that I was. That might be the toughest thing for you. And so naming those, writing them down, and then thinking about, for each one of those things, do you have options for cure? Is this something that could be changed? And sometimes it is. So if the toughest thing for you is constipation, that may be something that we just need to find the right doctor to work on it for you. It may be something where you need to adapt or do some coping to get with it. And so, to go back to the grandson example, maybe you won't be able to play the way you wanted to with your grandchild, but you could still spend time with them. You could still share stories. You can still share pictures and do other things that would still allow you to fill that need. And at the same time, to cope with that. And then lastly, for all of these things, to have compassion for yourself and have compassion for other people who are going through similar things. Kristen Neff, who's done a lot of work on self-compassion, I think one of the things that she mentions, which I think is so important, is recognizing that we're not alone in our suffering. We feel alone in our suffering, and our culture makes us feel alone in our suffering, but we're not. And there's a lot of other people who are going through similar things. And just knowing that and sending those people also our best wishes and loving kindness, I think can help us with overcoming our own suffering. With applying this mindset, we also want to look for opportunities for joy. And so what are the strengths, the values, the loves, joys that you carry into this illness? How have you gotten through tough times before? And how can you stay connected to these important parts of who you are and bring value to your current situation? So that could be, I've always been a strong person. I've always been creative. I've always been a problem solver. To get out of this state of paralysis and start using those skills and ideas to work on new opportunities. And again, sometimes there are things that we can adopt. Maybe it is, and this has happened a lot, as I want to get back more into my church service. I want to spend more time with family. Sometimes it's about adapting. Maybe I'm not going to be able to climb mountains the way I used to, but I can still go out to the mountains on weekends and spend time outside and do some lighter hiking than I used to. And maybe there's new opportunities. Maybe you've always wanted to do painting, or you always wanted to do music or choir or something else, and now's the time to do it. There's never a better time than now to look at things for joy. And the last part of this mindset is to find your people, so finding community. So who in your personal and healthcare community can you turn to both to share and offload some of your suffering and to celebrate your joy? And that can include, on the healthcare side, doctors, nurses, social workers, chaplains, therapists. It may be that you need to expand your connections on the healthcare side, occupational therapists. And on the personal side, friends, family, spiritual community, neighbors, support groups. I would say one of the biggest joys of the work that I do is seeing people make new connections. Because as much as you may feel embarrassed and afraid of asking your neighbor for help, I can almost guarantee you that they are looking for an opportunity and waiting for you to ask them. and that there's a certain amount of strength and grace that it takes to ask for help. But if you're able to do that, you're actually giving this other person a gift, because people feel good when they're able to give. And I could say there's never been a better point in history to do it. We are such a disconnected society. People are hungry for human connection and are hungry for the opportunities to help. And so you can give them that gift if you have the grace and the humility to do so. But it's a tough thing. So moving on then from the self-care concepts, how can we get more from your current healthcare team using these palliative care skill sets and tool sets and framework? So we can use these 5 pillars, and we'll go through them each one by one, of non-motor symptoms, emotional and spiritual support, preparing for the future, family support, and specialist palliative care, to improve the care that you get. And I'll go through these again in more detail, but the basic skills for non-motor symptoms is to set the agenda for your visits, and you can use a checklist to do that. For emotional and spiritual support, generally going outside the medical model to find counselors or other peers. To prepare for the future, you can start important conversations using a question prompt list. For family support, important to ask for what you need, and that can be a caregiver checklist. And then lastly, for specialist hospice and palliative care, recognizing that you have the right to get referrals, and that could be for specialist palliative care, it could be for a pain specialist, GI specialist, whatever it is that you feel like you need. So to go through these in a little bit more depth, the most commonly missed symptoms in Parkinson's are non-motor symptoms. And there's a lot of research supporting, including a paper we just published, showing that less than half the time people have their pain or depression or constipation addressed. And a lot of this is that patients don't know who to ask. And oftentimes there's some passing of the buck, that the primary care doctor feels like it's the neurologist's job. The neurologist feels like it's the primary care doctor's job. And so nobody's addressing it. But you can say, you know, the buck stops here. I really want to make sure we find someone to help me with pain or sleep or constipation. And then I put a highlight here on the bottom, is asking the question, could any of these symptoms be side effects of medications? And that's one of the, again, the favorite things that I like to do in clinic is to, before I prescribe anything, I like to deprescribe and just make sure that the doctors and medicines we're using aren't accidentally causing some of the symptoms that we're hoping to get rid of. So moving on then to emotional and spiritual support, important to go outside of the medical model. And I would add one other thing here that I didn't say, which is that people with Parkinson's and related conditions do have psychiatric anxiety and depression and can have chemical imbalances, just like with dopamine, with serotonin and other things. And so if you do have true anxiety or depression, it's chemical, you have moods that are coming out of the blue, you don't know where they're coming from, you don't feel like you can manage them, you can get help for that as well. And that could be medications, could be a psychiatrist, but if what you're experiencing is normal ups and downs and the challenges of having a serious illness, the challenges of loss of independence and other things like that, chaplains, spiritual community, psychologists, social work, support groups, friends and family can all be resources to help you on this journey, to help you feel less alone, to help you just normalize it. Sometimes the most important thing I do is just name something for somebody to let them know that, you know, it sounds like you're experiencing pretty normal grief with this illness. And let's see what we can do to work on that. Preparing for the future, it's important to start conversations. And so these are some questions that you could use to start these conversations with your healthcare team. What is the best case, worst case, or most likely scenario for how my Parkinson's may progress? And part of the idea behind this question is that doctors are often afraid to predict the future. They think that you want them to have a crystal ball, and if they get it wrong, they're going to look stupid. But this says, you know, nobody can predict the future, but you probably know more than you're telling me about what's the best this might do, what's the worst, and what's the most likely. And as part of the roadmap, we can also talk about what symptoms might indicate that things are progressing. So what should I be looking out for so you don't feel like you're living every day at a time in the dark? How can me and my family be better prepared for the future? What things should we maybe start thinking about or doing now? And lastly, letting people know I want to complete paperwork to put my future wishes in writing. And again, there's no better time to do this than today. It's something that you can revisit and change over time. But when people wait for the right time to do this, it usually means it doesn't happen until they're no longer able to communicate. And so just really putting it out there, it's usually pretty quick. It's relatively easy to do. I actually have done it myself. And so it's something that we recommend that everybody does and looks into at least once a year to make sure that your family and providers know your wishes. Fourth is about family support. So asking what you need, and this could be a carer checklist. And these are some of the common things that I think family oftentimes need coaching and reminders on. One is self-care. So if you are a care partner for somebody with Parkinson's, it's not a sprint, it's a marathon. And so really important that you don't burn out and that you make time and space for yourself. People need emotional, social, and spiritual support. It's tough being a care partner or being a caregiver. And so having somebody to talk to either in your family or oftentimes outside of your family, sometimes peers or support groups can be helpful, but just making sure that you have people that you can talk to so that you can be supported as an individual. Carers often want to know more about the future, sometimes more than the patient wants to know so that they can be prepared. They want caregiving skills so that they feel competent in providing the best care possible. And sometimes people need extra help at home, which could range from help with bathing to cleaning, to just having some time where they can get shopping and other things done. But those are all very reasonable things to ask for. And then lastly is that there are times, and I'm going to talk about this in just a second, when you may need specialist palliative care and hospice, where doing the things that we just talked about just isn't enough. And so you have the right to request referrals to other specialists and for second opinions. And so this takes us to kind of the last topic here is what extra support are we talking about? So what does supportive and palliative care, specialist supportive and palliative care actually provide? So things that I do in my clinic and things that I think you can safely expect from palliative care can include help with challenging symptoms like pain and fatigue. Could be providing support around difficult but normal emotions like grief and guilt and worry. Can be help with exploring spiritual or religious issues. Can be getting extra support for family and caregivers, talking about the big picture, including a roadmap for the future. Helping to coordinate care and work on some of these practical issues, and then clarify your goals and how you want those values to drive your care. Most supportive or palliative care teams include either a palliative medicine or a neuropalliative care specialist, social workers, nurse, chaplains, mental health counselors, and then other people could be brought in or maybe part of the core team, including psychologists, occupational and physical therapy, speech therapy, and home health services. So you can consider a referral for palliative care at any point in your Parkinson's journey. This could be near the time of diagnosis to get your head wrapped around what's going on in your life. Could be to help with a difficult symptom like pain, grief, hopelessness, struggling, just in general with poor quality of life, feeling like your family needs more support, getting more guidance to help feel like you have a handle on what's going to happen in the future. Or difficulties with coordinating care. So those are all things that we do in our clinic. For hospice specifically, and remember this is just for, in the United States, this is end-of-life palliative care. The main things here are if your primary goal for care and treatment is comfort, so you would not want to go to the hospital if you'd had pneumonia or any other infection, that would be when you would think about hospice. So if you don't want to go to the hospital anymore, hospice can help you to do that. Other things could be maximizing your time at home with family and friends. If you want an alternative to future ER visits or hospital stays, so you can call hospice instead of calling 911 and someone will come to your house. And if you feel like you and your family could benefit from an extra layer of medical support. I also want to be clear here is that non-medical support, so aids and things like that, that's not part of hospice. That's a separate conversation. So to wrap up here for advocacy and activism, the first point I think is that we as a community, patients, families, nonprofits, healthcare providers, need to push more for palliative care. So this was an article I wrote with people from the Michael J. Fox Foundation and Parkinson's Foundations and patients and caregivers in the journal Movement Disorders that we need to move beyond cancer in terms of thinking about palliative care. Regarding activism advocacy, a big thing that I'm working on right now is trying to raise standards of care for everybody living with Parkinson's. And as one first step in that, I'm co-leading a project with the Parkinson's Foundation, where we are working to make palliative care, integrated palliative care, a new standard of care at every center of excellence across the country. And our hope is that if we're able to do this and do this well, other centers are going to want to do the same thing. And everybody who's training at these centers is going to leave with this philosophy in mind. And so that, maybe as a moonshot, that within 10 years, everybody with Parkinson's is getting this type of high quality care and that their families are getting this type of high quality care. I would also say because of this initiative that there are in almost every state, not every state, but in almost every state options to get palliative and supportive care if you have Parkinson's disease. We also recognized when we were doing that study and some of the other work that I did, that it's one thing to raise standards of care at academic medical centers. It's a very different challenge to try to raise standards of care for people who are getting their care in the community. And so we are actually about to publish a study, and we're in version 2.0 of this, of something called the COPD study, which is Community Outreach for Palliative Engagement. And this is a study where we are working with community neurologists and we're training them in palliative care. And then we're working with the Family Caregiver Alliance so that if you're living in rural South Dakota or Alaska or Arkansas, which are some of the sites in our study, that you can get that kind of wraparound care living where you're living without having to go to the nearest academic medical center. And we have partnered with amazing and caring neurologists across the US, as I mentioned, from Alaska to Maine to Arkansas to Hawaii, who are working with us to make this a reality. And so if you're interested, feel free to email me or you can look up the study. And we'd love to get more people involved in this study. So as I said before, you have the power to improve the care you're receiving right now, and you also have the power to change care. So would really encourage you, and we can talk more about how to do this, about grassroots advocacy. This could include with the Parkinson's Movement Disorder Alliance. I'm sorry, I didn't put this here on the slide, but also the Parkinson's Foundation, the COPD study, the International Neuropalliative Care Society, which has patients and families who are members, but we're all working together to try to make palliative care for everybody a reality. And the Parkinson's Movement Disorder Alliance has been actually a key ally in that. And we've worked, and Anissa was at the last INPCS conference, and we have a lot of thoughts and ideas about what we can do to keep pushing and moving this work forward. So as take-home points, and then we can have sometimes it looks like about 10 to 15 minutes for some discussion. That palliative and supportive care is person and family-centered approach to improving quality of life for anyone living with a serious illness, including Parkinson's. That palliative care addresses many important dimensions of care, including spirituality, emotional well-being, care partner support, planning for the future, that are often overlooked in our traditional biomedical model of care. So it's really about providing, again, whole person and family-centered care. You can use these palliative care concepts and ideas and framework to improve self-care and also to improve the care you receive from the current healthcare providers you're seeing by coming in with checklists and questions and coming in with this framework. You don't have to use the word palliative care, but the people who are caring for you, I think, will be able to respond to your questions and suggestions. And lastly is that specialist palliative care and hospice can provide an extra layer of support for people with more advanced Parkinson's, but also even early Parkinson's, challenging situations, people nearing the end of life. And you have the right to request this care. And we as a healthcare system are doing our best to try to grow these services to make sure that they're really accessible to everybody who needs them. So I will turn things over to Anissa, and then we will have a conversation and discussion.
Awesome. Thank you. This has been wonderful. And we are getting a lot of comments and questions. And so we'll start off with, you're talking about, integrating this into care, even at the time of diagnosis. And, often we think of comfort care or supportive type care as for later. So curious as to, for those that you've worked with that started this process at the beginning, how were they in terms of receptivity to it, and what kind of difference did you see in those folks versus ones who were just in traditional movement disorders care and not necessarily getting a palliative perspective?
Yeah, so I'll give a couple situations where of what kind of really early palliative care would look like. And so for the first situation, I would say, and this applies to everybody, almost everybody, is that for most people, getting the diagnosis of Parkinson's disease has been described as having a bomb dropped in your life. And so part of this idea of kind of primary palliative care and preventative palliative care is just to anticipate that for most people, getting this diagnosis is bad news. And that having a group clinic where people can go within a month of diagnosis to meet other people with Parkinson's, to get their questions answered, to get support for their family, should be a routine part of care, but that would fall under the umbrella of primary palliative care. The second thing is that there may be some special situations that come up. And so just to name one person who jumps to mind, one of my teachers, a woman who has Parkinson's disease, who helped me get into palliative care. She was 46 years old when she was diagnosed. She was working. She had 2 children. And as I was seeing her, I think part of the reason she was referred to me was I think she thought that she, in addition to having Parkinson's, also had depression. And as we talked further, it was very clear to me that she did not have depression. She just had a lot on her plate. She had a lot of stress. She had a lot of questions about her work and about disability and how to talk to her children, and grief and loss about her dreams for the future, which were going to be different, and how do I adopt and adapt. And so for her, it was really important for me and our team and our chaplain and social worker to have a few sessions working one-on-one to help her adapt and adopt to this new diagnosis. I would say, I guess, a third situation that comes up, not too infrequently, is that people may have non-motor symptoms like pain that are really challenging, and that can happen at any time in the course of Parkinson's. In fact, it's not uncommon. I would say a few times a year, I'll see somebody with Parkinson's who got a surgery, possibly an unnecessary surgery for shoulder or neck or back pain, and that didn't help. The surgery didn't help, and the general Parkinson's medications aren't helping. And so that would be another situation, again, where we would see people a lot earlier than people would traditionally expect palliative care would get involved.
Awesome. And one person asked, like, isn't all Parkinson's care palliative?
Yeah, it's a good question. I would say no. And I think it's an important distinction, and it's something that I feel like I oftentimes have to work uphill to educate medical providers. So palliative care doesn't mean, it's not the same thing as, what I hear oftentimes from neurologists is that, well, we can't cure Parkinson's, so everything that we do is palliative. And that's not quite true. So palliative care actually is a specific philosophy of care that's focusing on treating the total pain of a serious illness and involves a whole team. So treating somebody's tremor with Parkinson's is not palliative care. That's care that's biomedically driven. It's not in the palliative care framework. So doing DBS is not palliative care. Although one thing we were doing at Rochester and we did at Colorado was we added palliative care to people getting DBS so they have extra support. So I would say that palliative care is complementary to the chronic biomedical care that's given for Parkinson's disease, but is different. And I think it's really important, particularly for our healthcare providers, to understand that, because if they don't understand that, then oftentimes they feel like they already know palliative care and they're already doing it, and there's nothing else that we need to do or change, and that's simply not the case at the current time.
And I think maybe the sticking point for a lot of people is that they feel like they're competing. The palliative care and the biomedical model of care, they don't go together, but you're saying absolutely they do go together.
Right. Yeah, I would say
approaching it differently.
Right. I mean, one example of that, again, this is kind of counterintuitive to people, but the time of diagnosis is a time where a lot of palliative care is needed, and another time is DBS. So it's a big decision. There's a lot of shifts involved. For people without a caregiver, they may need extra support. For people with a caregiver, there may be adjustments in their relationship. And so, there's this amazing neuroscience and neurophysiology and biomedical care, and DBS is amazing and wonderful and can do great things. And it's good to have support for everything else, for the psychological and social and spiritual aspects and practical aspects that go with it. So I see the two things as intermeshing. The problem comes up, and I think the reason why there's this myth is that with hospice currently in this country, for most people, you do have to give some things up in order to get hospice care. And that's something that I'd love to see US policy change on. But with hospice care, the way it's set up in this country is that everything falls under hospice. And so sometimes people hospice won't pay for a Duopa pump, for example. Hospice won't pay for certain expensive medications. And so some of this is kind of an artifact of just the way US healthcare law and US healthcare policy is. But conceptually, there's no reason they can't coexist. And outside of hospice, there's nothing that prohibits you from getting palliative care. So DBS doesn't prohibit you from getting palliative care. Chemotherapy, if you have cancer, doesn't prohibit you from getting palliative care. It's only with hospice that you start to have those trade-offs.
Thank you for explaining that, because I think it's a very confusing concept for some people just because of the way our system is set up. And one person was wanting to know, like, how do I find a neuropalliative specialist in my area? I love that, the centers of excellence are now, taking on that. But if they're not in an area where there is a center of excellence, is there any way to search for someone that might have that specialty?
Yeah, it's a good question, and it's easier than it used to be, but it's not always easy. So a few suggestions of things that you could do, and actually I could put in the link, or I could send it to Anissa. I think I wrote a blog about this recently. So one thing you could do would be to start with if you are in a state with a center of excellence, you could see if they do have neuropalliative care or if they've partnered with a palliative care provider. So that's easy. You can also see if maybe there's a palliative care. Actually, I'm trying to remember the year. I think it was 2015 that every academic medical center now has a palliative care program. Most of those, but not all of them, have outpatient palliative care, and most of those will see people with non-cancer diagnoses. So that could be an option. But outside of that, I recognize that there are parts of the country and places where that's not going to be an option. For people, as an example, for people in the New York area and around, I will see people out of state, and I think a lot of palliative care providers may do that. Using some of these tips and tricks that I gave you may allow you to upskill the providers that you're currently seeing. And then I would say, short of that, unfortunately, is that we're working on it, and that you could help us work on it by really trying to push for this model of care. Even asking about it, I think, is important, because it gets on people's radar screens of, oh, actually, this does make sense, and this is something that our hospital or our center or our clinic should be providing.
Yeah, and we're getting questions about, when are the centers of excellence going to roll this out? How do I find them? And you can go on the Parkinson Foundation website and look for where are their centers of excellence, where they're all located. And yes, thank you for Palliative. I know she's been dropping links in the chat, so thank you for that. There's another question, and I know this is not available.
Oh, I could actually, one other thing to add is that CAPC, and I guess if you want to drop a link to that, or I think it's just www.capc.org, also has a list of palliative care providers. And so even if they're not Parkinson specialists, that palliative care providers can potentially provide a lot of this care. And I guess the last thing I would say on this is that even if you don't have a neuropalliative care specialist, if you could get your palliative care provider to talk to your neurologist, they may be able to work together to provide the optimal care possible. And I think that's how a lot of us got started. I know for myself, I learned a lot from Jean Kuttner, who's a palliative care doctor, and vice versa. She learned about Parkinson's, I learned about palliative care. And so if you can get two compassionate healthcare providers who know these two skill sets to work together, you may be able to get the care that you need.
So we had a question, again, this is not available for every state, and some find it kind of controversial, but this person is considering a medically assisted end-of-life option in New Mexico. They have a terminal diagnosis, but I'm confused about whether Parkinson's is considered terminal. Usually it's not, but in Colorado it seems to be, and wants to know what's the story with that.
Yeah, so it is. So Parkinson's disease is the 14th leading cause of death in the United States. So if you look on the CDC website, Parkinson's disease is the 14th leading cause of death. So it absolutely can be listed as the reason for doing medical aid in dying. And I did write a paper. We could put this in the link as well. Actually, there's two papers recently of relevance to this conversation. One is one I wrote, I think 2 years ago now, that talks about different predictors of end of life in Parkinson's. And those could include things like weight loss, problems with swallowing, particularly for liquids, recurrent infections like pneumonias or bladder infections, loss of mobility, accelerating progression. And then we wrote an editorial with a number of people, including Bas Bloem in the Netherlands, about Parkinson's as a terminal illness, and about what is the data behind that. And so you can use those papers actually, if you need to, if your provider is not up to date on things, that Parkinson's absolutely could be a qualifying illness for medical aid in dying.
Well, and we understand that not every city and every state has palliative care in the framework that you provide it and others do, but we're moving in that direction. And I think, you've given us a lot of tools and even ideas that we can start being, advocates for that change. So I would love, if we don't get all of those links for everyone now in time to drop in this chat, we will get them and make those available. Either we'll send them in an email to everyone afterwards, or we'll put them with if we can, we'll put them with the link for the video recording of this.
Two other thoughts I had to add with where can you find it. So one thing that's important to know about the palliative care framework is that it can be done very well with telemedicine. I even have visits where we do it by telephone. And at UCSF, the majority of the care they provide is by telemedicine. So you don't necessarily physically have to go to a center. At least a lot of centers are willing to see people even for the first time virtually. And there are also groups, I don't know if you've talked to them or worked with them, there's a group called Synapticure, which provides movement disorder. And I just talked to them last week, and they're looking to provide more neuropalliative care. And so that may be another potential option in the future. But I know their providers are very good and are thinking about things and would be responsive. And we're working on a partnership between Synapticure and INPCS to try to up their game and up the availability of neuropalliative care across the US.
Wonderful. Well, I want to thank you so much, Dr. Kluger, for your time and your expertise today. For all of you who you've been watching this chat, you can save your chat. There's been several things that have been dropped as far as links. We provided some supplement material to kind of help you on this journey. A roadmap to care, a document on asking for help and planning for the future, all the things that Dr. Kluger just reviewed. So save your chat, just go over there and click those 3 little dots at the bottom of your chat box, and that should save it to your device. And I want to thank you, Dr. Kluger, so much. This has been a really great conversation, very helpful. We have a tradition at PMD Alliance, and I think you can probably see everybody, but if you don't have your video on, I please encourage you to turn it on, because we want to send a wave of gratitude to Dr. Kluger for this great conversation and for the resources that you offered us in this today as well.
Thanks so much for having me.
Thank you. And thank you everyone for joining us. This video will be available in the next day or so, and we look forward to seeing you at the next one. Take care.